Next is a short case discussion for 15 minutes on examination of thyroid swelling by Dr. Nirja Bharadwaj, Professor P.J. Chandigarh.
So all of you must have done a thyroid case in your lifetime, isn't it? How many of you have conducted big thyroids? I can see only a few hands. How come? You must have done lots of thyroid cases by now. Okay, let's start off with the patient which we are given here. She is a 36-year-old female and she has a huge swelling in front of the neck which has been there for about 12 years. And since the past 1 year, it has started increasing in size. She gives a history of difficulty in breathing in the supine position, that is when she lies down. And she also has a difficulty in swallowing with menstrual disturbances. Now, if you look at this, this is the history which is given to you. Do you want to ask anything more out of the patient to know more about the patient or not? Yeah, please speak out.
Any thyroid
Yeah.
features?
So you want to say that you want to ask about the history of thyrotoxicosis, right? So for history of thyrotoxicosis, what history would be there in the patient?
Any tremors she would be having, any palpitations she might be experiencing.
Anything more? She may be complaining also of eye signs, you mean. Even eye signs may not be there. Then is any other history which is important?
Palpitations and secondary thyrotoxicosis.
Nervousness, anxiety, depression, or diarrhea, insomnia. So basically you need to know about the history of thyrotoxicosis. Is the patient having some kind of thyrotoxicosis or not? You can also ask about myopathy. Is the patient having any kind of myopathy or weakness in the limbs, which will also signify secondary thyrotoxicosis. So you need to know all those things. So let's assume that this woman, this is the lady whom you will be getting anesthetized tomorrow. So you have gone and seen the patient, you have taken the history, and this is how she is presenting. So what are you going to examine in this patient, which is going to be relevant to you in your management? Yeah, who's going to say?
Ma'am, in inspection, while talking to the patient, I will ask patient's attendant whether there is any history of change in voice.
Okay, so you'll take the history of hoarseness.
Yes, ma'am.
So what does that mean? What hoarseness will, what information will that give you?
Ma'am, whether there is any involvement of any nerve damage,
Recurrent laryngeal nerve.
recurrent nerve
Okay.
damage, or
So
any
that comes in the
compression.
history. Basically, you will be asking about the history, whether the patient has any hoarseness of voice.
And I will also ask about palpitations.
That's
That's
fine. We discussed all those. What I want you to tell me is that once you examine the patient, isn't it? The examination which you will conduct for this patient, what will you focus on? Do you want to see something in that?
I like to look for any retrosternal extensions, like
Fine.
any distended
So,
neck veins.
yeah. So for retrosternal extension, how do you find out that it is, where will you suspect by your clinical examination that it is?
To raise her hands, and I will look for any raise in JVP or engorgement.
So raise the hands where? I mean, you should specify how you should raise your hands. In what way?
Elbows by the side, yeah.
Like this. So you should raise your hands up close to the ears, and you have to keep them there for some time, for a few minutes. If you keep your hands like this for a few minutes and there is congestion of the face, or there is some degree of cyanosis or bulging of the veins, then you know that the patient may have a retrosternal extension. Is there any other way which you can find out about it? Sternal percussion. What does sternal percussion tell you?
Dull percussion will be indicative of a retrosternal mass.
So will it be a dull note,
dull
or whether
note.
it will
A
be
dull note on percussion.
So it will be a dull note.
Yes, ma'am.
Okay. What else? It is very simple thing. Yeah. So just ask the patient to keep your finger here, ask the patient to swallow. If you are able to get below the swelling, it is a possibility that the extension is not there, right? So one part is that you will look out for the retrosternal extension. Now what else do you need to see for in this patient in addition to that?
Vital parameters, ma'am. And look
Vital
for tachycardia,
parameters. Why they are important to you, the vital parameters?
and look for presence of any tachycardia or irregular heartbeats.
Okay. So why is tachycardia important? He is saying I'll look out for the heart rate, and if there is tachycardia or arrhythmias, why do you think they are important? And why do they occur in this patient?
So one of the earliest signs for thyrotoxicosis.
It is of the earliest sign of thyrotoxicosis. Anything else?
They are more prone for atrial fibrillation.
They are, who said that? They are more prone for atrial fibrillation. So why they are more prone for atrial fibrillation?
Underlying undiagnosed thyrotoxicosis.
And what type of, you said atrial fibrillation, right? So can she have ventricular arrhythmias too? Or they are focused only on the atrial arrhythmias? The atria is more sensitive to the effect of the thyroid hormones. So basically, it is the thyroid hormones which are in excess and which are causing tachycardia, the sympathetic stimulation, and the atria are more prone for the action of the thyroid hormones as compared to ventricular. So that's why you have more of atrial thing. So fine. So in hemodynamics, you have seen the heart rate, and you have also tried to look out for any arrhythmias which you may feel. What else? What else you need to see? Airway. In airway, what do you see?
We see the Mallampati classification.
Okay, so what is Mallampati classification? Can you
Class
tell
1,
me?
2, 3, 4.
Yeah.
Class 4, 3 and 4 denotes difficult intubation. So we'll be prepared for the difficult intubation while intubating the patient.
Okay, so is a Mallampati assessment going to give you an idea? Suppose this lady, she has a Mallampati class 1. So this means she doesn't have a difficulty in intubation?
We will face a difficulty when we give muscle relaxant. It might cause difficulty during
So for this patient who has got a huge swelling, Mallampati classification may not be so important as such. It may be Mallampati 1, but your anesthesia will put you, the patient will go into it, obstruction, and you may not be able to intubate it. So basically that's not the only thing. You do a Mallampati classification, but that doesn't help you out in this case. What else do you need to do? One person please, stand up and tell me.
We have to do a cervical lateral view of
Neck X-ray lateral and AP.
Yeah?
Neck X-ray lateral
X-ray lateral view.
and AP.
I was talking about the examination, that's fine. When we come to investigations, we'll do that X-ray thing. But in an examination, do you need to see something more?
Indirect laryngoscopy.
So that's also a test. That's not a, that's an investigation. I'm talking about examination.
You check for tracheal deviation.
Who said tracheal deviation? Who said I'll look for tracheal deviation? Somebody spoke, please get up. Will you be able to palpate the trachea in this patient? Yeah, very good. Very good. So how do you do it? Yeah, so what do you do in that Koch's test? You press over the thyroid and patient will get stridor. So that means that it is a scabbard trachea, means it is being surrounded by the thyroid, and when you press it, it causes compression. So that's another thing. What else?
Patient is having difficulty in breathing on lying down.
Yeah. So she has a difficulty in lying down. What does that mean?
That means there is a pressure effect on the trachea.
Yeah, so she already has those symptoms, and the scabbard test with the Koch's test is going to reinforce that thing, that it is, in case of a problem, it is going to cause more compression, right? So that's what it is. So can somebody tell me what are the eye signs you look for in a case of a thyroid who may be having a thyrotoxicosis? What are the various eye signs? Who's going to speak?
There's first one is von Graff sign.
What is von Graff sign?
It's lid retraction. Then one sign is infrequent blinking, that is Stelvox sign, that is continuous staring sign. Then one is Mobius sign, that is lack inability for conversion or accommodation. Then Dalrymple sign is absence of wrinkles on the forehead. And Geoffroy sign, it's again visualization of the upper sclera when the eyeballs are rolled down slowly.
So basically the eye signs due to a long-standing thyrotoxicosis, you may find all these things. So you have examined the patient, and you have, in this patient, what is the positive history we have? We have on examination, we are able to go below the swelling. It's a huge swelling, maybe Koch's test is positive, and this patient, what will be the investigations you would like to do before surgery if you want to plan? So what investigations would you like to do?
I will go for the routine blood investigations, ma'am. The thyroid profile to identify whether there is two thyroid.
Okay, so this patient on the examination, the TFT was normal, right?
Yes, ma'am.
So the patient is probably not having thyrotoxicosis, but she has a huge swelling, right?
I will ask the chest X-ray and X-ray neck lateral, ma'am. Lateral and
X-ray neck lateral view. So what do you expect to see in that lateral chest X-ray or lateral view of the neck?
I already said like tracheal compression, ma'am. There is a long-standing goiter. There are more chances of tracheal compression.
So will you be able to see the tracheal compression in a chest X-ray in the X-ray or neck?
CT neck.
So CT will give you a much more idea of how much compression is there. But yes, an X-ray of the neck is going to give you the shadow of the air which you see. Whether there is any narrowing of the air shadow at some point where you will feel that yes, there is a compression, but the exact thing would be known only by a CT. So in this patient, would you like to do a CT or you will be happy with an X-ray?
I will like to go for a CT, ma'am.
So basically the CT, so how much, what do you expect? This patient has a history of having dyspnea when she's lying down, and she's also having a difficulty in swallowing. So how much compression of the trachea are you expecting with these symptoms? Do the symptoms give you any idea that how much compression is there? No?
Definitely compression will be there, but I don't know how much percentage.
It's an approximate thing. It's not that it is an exact thing. The exact would probably be known through a CT, but it gives you a rough idea that probably more than 30% or 40% compression is there. It is being produced because of that. Okay, what else?
Cardiac status, ma'am. I will assess the cardiac status by doing echo, ma'am.
You will directly do echo without doing an ECG?
ECG.
So you will do an ECG first. And what will you like to see on the ECG?
Sinus tachycardia, ma'am. There will be, the patient will be in thyrotoxicosis, there will be.
So you like to see for the heart rate. You want to see what is the heart rate of the patient. You want to see whether there are any arrhythmias or there is any evidence of LVH.
Yes,
in a thyrotoxic patient, what is the effect of the thyroid hormones on the cardiovascular system? Please, batao.
Thyrotoxic patient is mostly a sympathetic activity that takes place. So there's increased heart rate, increased contractility, increased stroke volume. And if the patient is prone for ischemia, then there are chances of ischemic.
So basically the patients all have a sympathetic effect on the heart system. There's chances of increased LVH. There may be even chances of a cardiomyopathy. So it depends on how long the thyrotoxicosis has been there untreated. So these are the cardiovascular signs. So you will look up for the ECG, and if required, maybe an echocardiogram. What else? Somebody was talking about some cord I will like to see. So why is an pre-operative IL important?
For assessing the movement of the vocal cords.
Who's speaking, please? Yeah.
It's like a baseline. We need to take it. We need to get an opinion for an indirect laryngoscopy, so that we can see the vocal cord movement if it's adequate or not. Because as the compression stiffness are there is a possibility the recurrent laryngeal nerve is being compressed. So post surgery, if there is going to be a problem that the vocal cords are actually getting damaged, sorry, the nerve is actually there's a problem, then the vocal cords.
So basically, you need to know that pre-operatively are the cords
normal
moving or not, and they are intact.
Yes.
Because in this patient, such a big.
She's probable.
Very fast. Can I take few more minutes? Okay, so we do an IL scopy, and let's talk about the anesthesia. Now this patient is going to anesthetize her tomorrow. So what do you plan? How do you plan to, induce this patient or intubate this patient? Who's going to tell me, please?
Induction agent, preferably thiopentone, madam.
Okay, so you are going to use an induction agent like thiopentone.
Yes, madam.
So why did you choose GA and why did you choose thiopentone?
Ma'am, first thing, thiopentone suppresses the peripheral conversion of T4 to T3. Thyroid.
So is the patient thyrotoxic or thyrotoxic?
If the patient is thyrotoxic?
No, we are talking about this patient. We have a patient with us, isn't it?
Yes, madam.
So when did you see that photograph of that patient?
Yes, ma'am.
So do you have anything in your mind that how I am going to intubate this patient? You didn't feel scared about anything about it. You felt I can go ahead, give thio and muscle relaxant and intubate and I'll be okay.
Ma'am, usually with difficult airway cart readied and...
No. Who's going to tell me? Tell me, how are you going to manage this patient?
Since the patient is giving symptoms of dyspnea in the lying down position,
who is speaking? Please stand up first. Okay, fine.
Yeah, the patient is giving symptoms of dyspnea in the lying down position.
Yeah.
So I would not want to induce the patient, and I would want to go ahead with an awake fiber optic intubation.
Correct.
Awake oral fiber optic intubation.
So how are you going to do that?
First, we will take consent from the patient, explain the procedure one day prior, that what exactly we are going to do and why we are going to do. And on the morning of surgery, have a difficult airway cut, and we have to anesthetize the airway.
So how are you going to anesthetize the airway in this patient? When you do awake fiber optic, what are the various nerves which you block?
This, because there is a swelling in front of the neck, so nerve blocks are not possible. So
they are not possible?
Because anatomical landmarks are difficult.
Here they are not possible. Can you do it intraoral?
From fiber optic we can inject
spray as you go.
Say go
but
technique.
you can ask the patient to gargle.
Yes.
You can ask the patient, so that will anesthetize the rest of the part.
Yes, nostrils we can anesthetize using lignocaine jelly or serial dilatation using nasopharyngeal airways. We can anesthetize. Do
you want to go nasal? Why don't you go oral? We don't need a nasal intubation in this patient, do we?
No, and no, we will not anesthetize the nose.
So you are going to do an oral thing. For that you can use gargles and then you can spray as you go. Probably that is the technique. Now suppose...
Or nebulization.
Nebulization is there. Now there is no reason, but we don't need to go through the nasal route in this patient. Now can you tell me, suppose this patient, she refuses to undergo awake fiber optic, then what do you do?
Ma'am, we can use LMAs.
LMA.
It is not contraindicated, we can use it.
No, it's not contraindicated, but do you want to plan the surgery on a LMA?
Ma'am, we can go forward with normal endotracheal intubation without...
With GA?
With GA, yes ma'am.
So how do you do that?
Ma'am, if the thyroid swelling is big enough, then we can lift it up and then do the intubation.
When do you lift up the thyroid swelling?
After we do the indirect laryngoscopy. After the patient is induced.
Basically, why should the swelling sit on the trachea? Why it should be like that? Because when you give your anesthetic agents, you are relaxing the whole oral airway, the musculature. So that is the reason why the thyroid swells. At that point of time, you need to lift the airway. Now tell me, what is the role of video laryngoscopes, as she said? Can we use video laryngoscope for an anesthetized patient?
Another option is that we can do a chexoscopy. We can do a chexoscopy with one legal can spray, 10% spray. We can spray over the epiglottis and vallecula.
In an awake patient, you spray into the oral cavity with local anesthetic and you do a check laryngoscopy and then you want to do that. That is what you mean? Yes. Maybe some people want to do it, but I wouldn't do it. I won't do it. Don't you think that video laryngoscope is a good idea?
It improves.
Anju, you want to add something?
I just want to ask a question for those of you who want to do a direct laryngoscopy after anesthesia induction. The moment, or those who want to put an LMA, the moment you do that, do you think your airway is still unobstructed? Yes? Where is the obstruction? It's at the lower level. Nothing is there on the supraglottic area. So this is not a backup device. So what would be your backup device, say, if you fail to intubate? It's a big thyroid that is there.
Rigid bronchoscopy?
Rigid bronchoscopy.
Because even a tracheostomy would be difficult in this patient. Even a cricothyrotomy would be difficult in this patient. If you go according to a difficult airway algorithm, when you go through the various levels, you will know that where is the problem. The problem is basically to secure a surgical airway and basically to secure an airway. So you need to have a rigid bronchoscope ready to intubate. There can be many reports of putting an intubating LMA and then passing a tube through it and all that, but basically the first thing to do is that. Now somebody can tell me that what are the complications you expect post-operatively in this patient?
Recurrent laryngeal nerve injury, RLN palsy post-surgery, and during extubation we can have problem.
Basically there are the two issues. One is that you think the surgeon will tell you, I could not identify the nerve. So you are thinking that probably there is an injury to the nerve. Second is, it's a long-standing goiter, isn't it? 12 years.
Tracheomalacia.
So tracheomalacia is another issue. So before you extubate, what you need to do?
Cuff leak test.
What is cuff leak test?
We have to deflate the cuff and if we can auscultate.
Auscultate where?
Ma'am, here.
Where? I can't see. Yeah, come on.
Ma'am, cuff leak test is first before the deflation, before the extubation, we have to measure the inspiratory and expiratory volumes, and then after, and we have to do thorough suctioning before deflation. Then after deflating the cuff, we have to do 6 cycles of inspiration and expiration, and we have to measure the volumes. Then the lowest 3 volumes of expiratory volumes is averaged, and it is compared to the inspirating volume before the cuff inflation.
Right. What is the second way of going about it? Which I would go in for, because this is too complex, you wait all those time. I would prefer to extubate on something else.
Fiber optic.
One is fiber optic, one is tube exchanger.
Tube exchanger.
So in case there is a tracheal collapse, you can immediately intubate the patient again. And for looking at the vocal cords, how do you want to visualize the vocal cords before you remove the tube?
Withdraw.
I would like to do a deep extubation.
I would reverse the neuromuscular blockade completely and then keep the patient
airway is difficult. How will you
with the
do
tube exchanger in place?
difficult
And
mass
we'll look for the movement of the vocal cords.
You have to remove the tube to see the cords.
Yes, ma'am. We would remove the tube and keep the tube exchanger in place, and we will do DL scopy.
So why do you need a tube exchanger anyway? Suppose you don't want to use the tube exchanger,
issue in case
but
she
you
might
can do it some other way also?
We can extubate the patient on deep plane, and after extubation the patient in the deep plane, we can put a nasopharyngeal airway, and through that we can pass a fiber optic, and we can first we have to reverse the patient. After reversing, we can extubate the patient on deep plane. Then we have to put a nasopharyngeal airway.
So if it comes to that, why not? People have even put a supraglottic device, then they have gone through the supraglottic device, seen the vocal cords, and brought out. You can use even video laryngoscope like TrueView, etc. to visualize the cords when you are removing the tube. That's fine. Okay, thank you very much.